Good afternoon, everyone, and thank you for joining us for today's Leapfrog Group webinar, Building a Safer System, the Role of Culture, Trigger Tools, and AI. I'm Haley Burgess, the SVP of Provider Care Management Portfolio at Inovalon, and we're thrilled to welcome you on behalf of the Leapfrog Group and our incredible thought leader panelists. Your time is the most valuable asset that you have, and we are grateful that you've chosen to spend a few moments with us in your busy day today. And whether you work in quality, safety, risk, or clinical leadership, you're here because you care deeply about protecting people and advancing the systems that we rely on to do just that. So in this session, you'll hear how electronic triggers, AI-powered detection, and a culture of safety are helping organizations move from reactive or to proactive safety practices. You'll learn how automation complements, not replaces, manual workflows, and how early detection drives faster intervention, and how organizational culture plays a critical role in making all of that work. And before we dive in, I do want to encourage you, use the Q&A function throughout today's session, submit your questions, and we'll address as many of those as the time allows. And we'll also have several polling questions throughout. So please participate with us. We'll try to be as interactive as possible to keep a very lively group today. Again, excited to be here. Now, let's get started with our panel. And I'd like to welcome our speakers today. And first, we have with us Dr. Chris Emerson. Chris?
Hi, excited to be here today. I am a pharmacist by education and have been working on the Vigilance products, which is now part of the Inovalon family, for almost 12 years now, primarily on the pharmacy antimicrobial stewardship and more recently on the safety event reporting platform. Really excited to share some of the insights that I've been able to gather from working with our various customers and wonderful safety and quality specialists across the country.
Terrific. James?
Hi, excuse me. Hi, I'm James Hoffman. I lead quality and safety at St. Jude Children's Research Hospital in Memphis, Tennessee. You might know about our hospital. We're focused on children with cancer and other catastrophic diseases. So clearly high risk, complex care in our setting. And I'm excited to be part of this because I enjoy opportunities to think beyond the niche of St. Jude. And I often think that St. Jude, with our complexity of many children with cancer and on clinical trials, can be a bit of a lab that if we can do it right at St. Jude, it can apply almost anywhere, even with our unique patient population.
Thank you, James. And thank you both for your time and expertise today. These two gentlemen are wonderful practitioners, and I've spent a lot of time with them over the years and really, really looking forward to our time together today. And let's jump in. This audience in particular is acutely aware of the growing body of evidence and opinion articles that draw attention to our continued struggle to provide safe care for patients in our healthcare communities throughout the U.S. And Dr. David Bates and his colleagues published in the New England Journal of Medicine a retrospective cohort study examining randomized sample of patients across 11 Massachusetts hospitals. And their findings were both interesting and alarming on several fronts. And for me, the most critical finding is that 1 in 4 hospitalized patients suffer an adverse event that negatively impacts their health. And about 1/4 of those events could have been prevented. And these events were focused in medication management, healthcare associated infection, nursing care issues. You're not surprised by any of this, but I think as healthcare professionals, we have much to do yet. And I appreciate this quote by Leah Binder, which I think is timely for our presentation today, that sums this up nicely, that patient safety is relentless, never ending quest to put patients first. And so if we think about with ECRI's report for 2025, some of the top patient safety risks, and I've highlighted a few on the next slide that really talk about diagnostic errors persisting, healthcare associated infection outbreaks, patient discharge coordination failures. You have your medication errors, transition of care, communication issues, and finally, this medical gaslighting, clinicians not validating patient and family concerns. And the medical gaslighting is an interesting terminology, but I think it speaks well to the culture of safety for organizations. And simply put, the culture of safety, in my opinion, is a shared commitment and responsibility of all the staff, from the C-suite to frontline employees, where we take ownership of preventing harm with empowerment to speak up and then working together tirelessly to improve care. And James, I'd appreciate your thoughts on how to build a culture of safety. And also, how could this assist with this issue of medical gaslighting?
Yeah, I think the first thing I'd say is, you know, culture of safety gets thrown around a lot and for a long time, and it's a real thing and it's an important thing to work on. I haven't heard until this report the medical gaslighting framing, and I think that's interesting and kind of puts a different lens on it. Uh, you know, one of the things I think a lot about with safety culture, and uh, I think you could think of safety culture as a subset of organizational culture, is um, there's two general ways I think to look at culture sometimes, and safety culture is part of it. You know, it's kind of passive. It's what it is. It's you know, it's happening around us. It's how people do things just automatically, or it's a leadership responsibility, and things that leaders do set the culture, and it's an active thing that an organization and leaders especially do to establish, you know, this is how we do things, and it's something that's dynamic and nurtured and sustained. And so you know, it's a good, it's a, I think it gives a clear word picture, or clear picture and a different lens on culture. And I would encourage leaders to really take it on and improve culture, understand it, um, prevent medical gaslighting, I guess.
Terrific. And Chris, how have you seen organizations use technology to drive culture of safety and improve event reporting?
Yeah, so what I've seen is certainly organizations, when they start using a technology like one that Inovalon has for event reporting, is they really focus a lot on streamlining the event reporting process and the forms for reporting safety incidents. A lot of times these are far too involved and long, and that will kind of hinder the reporting of events because people don't have healthcare professionals are burdened with a lot of other activities that they need to do, and they don't feel like they have the time to do the reporting. So really streamlining that event reporting process through leveraging things like auto population, where they can search for a patient and it will auto populate a large percentage of the event reporting form, really does minimize the burden. Also, I've seen a huge encouragement on reporting of near misses, and really highlighting and recognizing those as great catches. A lot of our customers are putting homepage messages on our safety event reporting solution that really calls out the great catches each month and identifies that great catch and really celebrates those to really enhance the culture of safety and get people excited about reporting those types of things. And those are very important for organizations to be able to understand where there are potential breakdowns in processes, and potentially be able to do something about preventing an actual event before it reaches a patient. So those are a couple of great examples. Another one more recently that we've seen a lot of is really ensuring that closed loop feedback to the reporters after an event is completed with its investigation. And we've identified ways to automate that process, where the reporter of the event will get an email back at the end of the investigation so that they know that the event that they took the time to report was investigated and there were actions taken based on the report that they made. So really engaging the staff to be involved in this process. It takes everybody, as Haley mentioned earlier, not from the top all the way down. Everyone has to be engaged in this process for it to be effective and to, at the end of the day, improve patient safety.
There are two items that you all both touched on that I really appreciate. And one is that Good Catch program. I think that's such a terrific way to improve your culture of safety, right? Celebrate what's being bubbled up to the top so we can address that, address it swiftly to get ahead of harm. And the other thing is over time, with your event reporting, you'd like to see the near misses and the good catches really improve, like really increase. And then you have your errors or events of harm decrease. I know that's the way I always wanted to see my data in the patient safety world, of looking at that and having a really nice trend over time.
Yeah,
Super.
one thing I'd add there, Haley, I think it's important with good catch, great catch, whatever however you brand it. I think organizations do it all different ways, and I've seen some really clever things. The one thing that we've been working on at St. Jude is don't just celebrate the catch, but do something with it and tell people what you did. And I think that's the next level with a good catch program, is actually use that nearness information and use it as a chance to say, you put in this near miss, we heard you, we did something with it, versus just a thank you, good job. But thank you, good job, it was used to improve a system.
Absolutely, James. It goes back to that learning community idea. So if we find it here on this unit, likely you can replicate that across your whole organization. And if you're a system, right, then a multi-system approach is really important as well. Great point. All right. So let's hear from our audience. We have our first polling question, and it's going to pop up on the screen so that you all can begin to choose your answer. But the question is, what is your biggest barrier to improving patient safety? So lack of timely access to safety data, staff burnout and workforce shortages, leadership does not prioritize patient safety, siloed departments and poor collaboration, limited training on safety best practices, and finally, outdated or manual reporting systems. You only have one single choice, and we have given you many to choose from. So, really curious to hear what the audience thinks about this. And I think this is a hard question to ask of sorts, but your top reason, I guess, is what we're really looking for, because certainly it can be multifactorial. All right, let's see what you all have said here. So it looks like siloed departments and poor collaboration is one of our top ones, along with staff burnout and workforce shortages. And I think we can all relate to that, right? We talked a lot about coming out of COVID, the staff burnout and the stress. And it's so real. And maybe it wasn't even just COVID. I think maybe it was highlighted more during that time. But healthcare is tough. And especially financially, as we're thinking about how do we run operations in a smooth and swift way, but then also optimize how we care for patients, it really is a delicate balance. So, looking for efficiencies in the system, looking for ways to really optimize how our staff use their time and efforts is super important. And this communication piece is so critical, right? We see it in transitions of care. We do see it amongst the departments, and thinking about ways for us to communicate better and get information in front of each other is very important. And we're going to talk about all of these things today. So thank you for that. Thank you for participating. All right. So as we move on to the second section here of our presentation today, I really appreciate this conversation. And James and I were together at a conference recently, and we were having this very conversation around the future of patient safety and how do you consider a broader context with this. And so, James, I'll send that over to you and ask you, can you give us some thoughts around this of how do we rethink patient safety?
Yeah, a few broad points. And I think these are uh, probably different levels of being novel and different levels of maybe diffusion into practice. So three ideas here, just to get us thinking broadly before we dig into event detection and technology. First, I think this is probably the furthest along, but switching to safety, not just patient safety. There's so much, and it goes with the previous question of the workforce challenges, and that if employees aren't safe, then how can patients be safe? And then the techniques and tools we use apply so well for patient safety, apply so well to employee safety. So maybe it seems funny to drop the patient sometimes, but the intent isn't to minimize the importance of the patient, but I think it's to be take a broader view and keep everyone safe, sort of safety for all. The next thing, which may be a bigger paradigm shift and less far along, is fundamentally what do you think safety is? And the way I've tried to summarize it is that safety isn't just avoiding harm; it's building resilience and adaptive capacity. And there's tons of theory and jargon that we could go into that we don't have time for today. Uh, you might be familiar with the safety one versus safety two idea, and there's a lot more that goes under that. But this is my attempt to just summarize all of that and say, what is safety? Is it just avoiding harm? And we haven't had bad outcomes today, so it's been a good day. Or is it something deeper, more nuanced, more complex that a team is able to respond and adapt and be ready for something unexpected? And so I'd encourage you to think more broadly and deeply. And then you might say, okay, James, you didn't use too much jargon there. I kind of understand that, but so what? What's next? Well, I think a starting point is to apply some of these new concepts. A starting point is the quality and safety leader that as I've talked to people and okay, what is this? What are these new ideas and how do you actually put it into practice? It was striking. The response I got was, well, the biggest barrier is the quality and safety leaders because they're happy doing things the way they've always done it. So the rethinking on this slide, the starting point might be the quality and safety leader needs to be the starting point for the rethinking.
I always like James' responses because he's innovative and he really pushes us to think outside the box and he's not afraid to say the hard things. And I appreciate that. And I think one of the points that you bring up of broadening the safety lens, if you will, as a practitioner, I'm a pharmacist by training too. And when I was leading groups of pharmacists, I would often think about how do I protect my staff and my team, as well as the patients that we serve and our visitors into our organization. And so I really like that concept, James. Thank you for sharing that. And so, as safety leaders work towards this comprehensive view of safety, how can organizations begin to get ahead of harm in a more proactive way versus reacting to this data and events? James?
Yeah, I think, and again, to be practical and try to apply some of these newer ideas, I like to think of event detection as a foundation. And we'll talk a lot today about different approaches to event detection. And I firmly believe you need both passive and active surveillance. You could kind of argue the amount needed of each, but I think that forms a foundation. And then uh, I think really where we're headed is what are your techniques to find risks, opportunities, however you want to frame it, beyond your event detection methods. And what what I see as the exciting application of these kind of new concepts in sort of safety science, safety writ large, I think it's given us a whole new playbook for proactive activities within safety. And so a simple way I can put it, and this isn't anything against failure modes and effects analysis, but I see that as kind of the classic, perhaps best well-known risk assessment method. And the simple way I would say it is, if that's your go-to and only proactive risk assessment method, I would encourage you to open up to other ideas and think differently and think beyond the FMEA, because we have more and more techniques that we can use to understand actually how the work is performed, and what's really happening in the system, which will inform improvements. So event detection is key. That's a lot what we're going to be talking about and how well you do that. But think beyond event detection as well.
Yeah, and this is a nice lead in. As many of us are feeling the tension in healthcare regarding AI transformation, the Cisco team reported a survey, and this was towards the end of last year, that while 98% of surveyed organizations report a growing urgency to deploy artificial intelligence, only about 13% feel fully prepared to do so. And so, this gap between the urgency and the readiness presents both a challenge and an opportunity for us. But the message is clear. AI isn't the future, it is now. But how do we use it safely and effectively? We need more than technology, right? This is going to require governance and transparency and clinical alignment. And Chris, I'd move to you to ask, what are healthcare organizations asking for as it pertains to patient safety?
Yeah, so I guess to level set, I mean, AI is a very broad term. So when the way I'll frame this conversation is really in the area specifically of natural language processing, machine learning, and large language models, and then some rule-based AI as well. And so a lot of the common themes that we're hearing from our user base are things like using NLP to detect and report safety events from documentation, or like churning through large amounts of textual documentation to identify safety incidents. So an example could be training a model to detect adverse drug events or falls or pressure injuries from provider documentation, to take that manual reporting component out and just pull in all of that information into a safety event automatically. Or using rules-based AI to detect and report safety events when specific criteria are met. And I'll talk a little bit more later about rules-based AI as we get a little bit further into the conversation here today. But an example of this would be patients meeting criteria for an HAI and then automatically creating the safety incident and pulling over all of the pertinent documentation related to that HAI to really streamline the investigation process and automate and kind of prevent that need for some of that double documentation, which is happening a lot in other systems today. Using NLP and large language models to summarize a safety event that's been reported and investigated. And some of these safety events that we see get reported and investigated have many investigative notes, attachments, action plans, measures of success, timelines, et cetera. And if a safety and quality professional is trying to kind of get their head around what's going on with an event, they might have to spend an hour or two trying to digest all of that information. And so we've been asked to be able to have some sort of a button they could push almost to say, give me a summary of all of the information that's been documented on this case to date. And that's a really fascinating and interesting idea, which could really open up time for people to do other things, and really streamline that process. We're also really interested in and have heard requests around using machine learning to identify patterns and anomalies and trends in large sets of safety event reporting data. There's massive amounts of information, as I mentioned, that gets documented in these safety incidents, and there's a lot of them. And it's really hard for organizations to digest all of that and really understand what's going on. And so using machine learning to identify those patterns and anomalies and trends will really allow organizations to get out in front of that harm and prevent safety events before they happen. So those are, I would say, the most common things that we're hearing right now from our user base around how we could use some AI technologies to really support the work that they're doing and to improve patient safety.
That's really helpful, Chris. And just to summarize, what I heard you say is there's definitely a desire to streamline the workflow, to automate as much as possible with event reporting and data in general, to summarize that data so that they can focus on the insights and using the data to look for patterns and how to get ahead of harm, but also having the time to focus on the improvements.
Right. Yeah. Less time doing those manual tasks and more time improving the safety of the organization through action and less spending time behind a computer reading and doing manual things.
That's right. So, James, what do you see as the biggest opportunities and risk in adopting these technologies in the healthcare system?
Yeah, I think the starting point there would be that there's many risks and challenges. I think the starting point is at a health system level, there needs to be kind of AI, or maybe you want to say predictive analytics and generative AI, however you want to couch it, um, a real governance model that what you have today, if you don't have something specific to AI, is probably not adequate. And I think health systems are all different places on this, but if you haven't at least started, that's an urgent thing because of, we could go on and on about the risks. The second thing I would add is uh, I think especially if we frame AI more in the realm of machine learning, large language models, I think there's a real gap in um, using those types of AI within routine quality and safety work. I think we see so much activity towards, kind of the patient care encounter, ambient listening, all sorts of chart summarization tools, which are great, but the busy quality and safety leader doing routine work that they know they they can only get so much done, and they always end their day with more to do. Those tools I think are more slowly emerging, and I think it's sort of an overlooked area of focus that's still slower to develop. Especially when we focus, like I said, on the more machine learning LLM aspects of AI.
And what challenges do you think organizations are going to have to overcome to fully realize this value?
I mean, I think there's a couple things. I think there is again, I would start organizationally, that I think organizations, health systems are at different points in how much they're jumping into AI and how much they have the governance, how much they're investing in it. And then it becomes a question of picking the exact use cases, and how much is the quality and safety leader going to push for use cases that problems they have, and does the energy and investment go somewhere else. I think when I think about quality, like a fellow quality and safety leader, are they positioned, are they advocating that these tools will help with routine quality work, or is all the attention and energy going to some other use?
Great. So let's hear from the audience around what is the biggest opportunity for AI in safety event reporting. And so you have a couple options here: detecting events that staff may miss, reducing reporting burden on clinicians, identify patterns and trends across systems, driving near real time interventions, not just documentation, and or we're still determining how AI fits in our strategy. We'll give you just a second. This is such an interesting conversation, and it comes up in any avenue that I've been in lately. The question of AI and how ready are we and what are we using? And it's really interesting to go to the trade shows like HIMSS and others where it's very tech driven to see what's coming. And these organizations, these vendors, tech companies are moving really fast in this space. And I think we just have to be careful, right? Like what you said, James, of being very cautious about the governance and how it truly affects patient care at the end of the day. There was an interesting post I saw in the last couple of weeks from IHI around a cardiovascular model that was being created, a machine learning model. And they found some problems with the model, the healthcare organization did. And they said, we're going to go back to rules based AI. That's a little more comfortable, right? We know how that works. It has a transparent feel to it. We can see exactly this algorithmic identification from a clinical perspective. And for this model in particular, for this cardiovascular one, they said, we're just not ready for machine learning with that. And that's okay. I appreciate that they tested it really well and made that hard decision. All right, the votes are back in, and it looks like identifying patterns and trends across the system, right? And Chris, this was something you absolutely touched on. This is what customers are asking for out of vendors. What are you seeing in these patterns? How can you bubble that up to us so that we see it faster and sooner and can intervene? And then also many still determining. And I think that's okay. It's a very thoughtful process. And then also driving near real-time interventions, not just documentation. Absolutely, right? We want to know what's happening. We want to be able to intervene as quickly as possible. That's terrific. Thank you all for entertaining our polling questions. Really appreciate that. Awesome. So we're going to shift gears a little bit now and talk about why does all of this matter? We're talking about electronic triggers, and studies estimate that 50 to 80% of medical errors go unreported in the US. And the underreporting really limits our ability to measure the harm, to identify trends, to have meaningful safety improvements, but also to compare ourselves. Like, are we doing a good job? And I would often ask staff when I was in the hospital of what keeps you up at night, or what is the next error or event that may occur on this unit? And interestingly, the staff knew. They often know the answers to these questions, but the voluntary reported data did not always fully reflect that conversation, right? As a leader, I would be doing walk rounds and I would be looking at our data, but sometimes what they would share really didn't make it to the data or to that information. And so, James, I would look to you for this one. Why do so many patient safety events and medical errors go unreported in the US health system? What do you think is happening?
Yeah, I mean, the reports and the slide makes the point of staff lack understanding about what should be reported. I think that's true. Uh, but this gets back to I'm not sure. I don't think we're going to be interesting. Someone would argue, but I don't think we're going to educate our way out of this. Like staff and the question earlier, burnout. And it goes back to the idea that staff are showing up to do a good job, and I don't. Maybe you can move the needle with some education and making it easier to report. But I think these kind of reports call out for more sophistication in event detection, not just relying on voluntary event reporting, having more of the active approach, and back to the earlier point of event detection as the foundation, and then layering on increasingly sophisticated ways to gather other information on risk and how the system is performing.
Great. And Chris, can you walk us through a few best practices that you've identified using technology to improve our awareness and ability to intervene in safety events?
Yeah, absolutely. So Vigilance now, which is now part of the Inovalon family, we started out in the clinical surveillance space back in the early 2000s and developed a rules-based AI engine. And that engine ingests data from the EHR and then creates alerts that users would intervene on, or still do, based on hospital protocols and procedures. And these rules were primarily created in such a way that they're focused on preventing harm from occurring, which is great. However, obviously, we know that safety events and patient events still happen. And so when we were developing our safety application, we realized that we could leverage that same rules-based AI engine in a slightly different way to automatically detect when a safety event had already occurred. And in Inovalon, we refer to this process as auto detection or electronic triggers. And rules-based AI will identify the safety event in the background and then automatically create that safety event in the safety management application and pull over all of the pertinent information related to that event and auto-populate a bunch of the fields in the safety event reporting form. And then that event is automatically routed to the appropriate reviewer for the investigative process. And so we have some real world data here that on the next slide, which is from Christus Health, who partnered with us by using the Vigilance Safety Management tool. And they used it beyond just for the auto detection, they use it for their voluntary reporting as well, and used it to standardize really all aspects of their safety event reporting. They did implement the rules-based AI functionality to automatically detect and generate safety events for 21 different scenarios. They implemented it at 19 of their facilities, and these scenarios were primarily focused on adverse medication events. They performed a retrospective study over an 18-month period and directly compared the adverse drug event reporting that was done voluntarily compared to those that were automatically detected from the rules-based AI surveillance. And the rules captured an average of 19 additional events per month per facility. And if we go to the next slide, it kind of will outline what that really translates to. And that represented a 400% increase in their ADR reporting versus self-reporting alone. And well, you might say, well, these maybe they weren't really events. Well, 77% of these auto-detected events that the rule engine found were actually investigated and categorized as safety events. The other 23% were closed as not safety events or closed as duplicate because someone had also voluntarily reported that same event. But with that auto detection, Christus also had a 66% increase in reported ADRs that were categorized as harm events over their baseline voluntary reporting alone. So a substantial increase in their event reporting in this particular area. And they continue to use this technology today to identify these adverse events. And since then, we've had several other organizations who are now using this technology as well. I don't have published data to share on the webinar today, but I can anecdotally tell you that we do have several other customers using this technology and are having also fantastic outcomes and increases in event reporting in the categories of events that they're looking at.
Right. And I think what's important for us, it's the next part, right? Like it's terrific that we're identifying more, we're gathering more information, but the point is that full circle of how do we protect people with this? How are we taking this data and implementing change faster? And that's the part we're still learning about. So in the next webinar, we'll report out on more of the outcomes because I think it's going to be really tremendous. So let's move to our final polling question. And so this one is around electronic triggers. So does your organization use electronic triggers for safety events? And so you have your potential choices here. We use electronic triggers routinely and have integrated those into our workflow, or we're in the early stages of exploring or piloting these type of electronic tools, and or we rely mostly on manual reporting, not using electronic triggers yet. We are new to this topic, and we're not really sure what our organization is doing. So we're really interested to hear how you all are addressing this with technologies moving so quickly. How is that affecting your organization, and how much have you been able to embrace this type of tool? And trigger tools have been around for a very long time, and I remember using the manual ones years and years ago, and it was really onerous. Like, it's interesting and it's important, but it was really hard to have staff focused on pulling that kind of information in a manual way. So I can really appreciate the electronic trigger side, of having information that's flowing in without a huge burden on our staff and our teams. And then furthermore, looking for those patterns and getting ahead of it. So let's see what our audience has to say here. All right. It looks like most of our audience is still relying on manual reporting and not yet using electronic triggers. And that's not surprising. I feel like the access to this type of data, or the ability to use your internal warehouses or databases to map that data, it's a real challenge to do it on your own. So I think it'll be interesting to see over the next couple years how this really plays out with organizations, of which route they go and how they're able to do that. Great. All right. So we'll keep moving on and have a few more topics to discuss with you all, and then we'll begin to open up with some of the questions that you all are posting into the chat. And we wanted to share this particular study with you guys that came out recently. And this was in the past couple weeks. So I thought it was so very timely that NACU has put out an ROI Q, or quality report, and it's providing some really clear evidence that quality improvement isn't just about doing the right thing, it's financially smart. And organizations that invested in this quality infrastructure, such as staff intensive training, AI powered surveillance and trigger tools, they're really seeing major gains in their organizations. And Christus Health reported a 50% reduction in serious safety events, and Kaiser Permanente over $6.5 million in cost avoidance within 2 years in their Northern California region. And so validation, right, that reducing preventable harm can really lead to measurable ROI and not simply clinical outcomes. And we want both. It's really important. And so, James, what strategies have you found to be effective in engaging your executive and financial stakeholders around this value of safety, patient safety investments, and particularly when translating quality outcomes into measurable ROI? Was there anything in this report, or just in general how you work with your executives? How do you make the case for quality?
Yeah, I really liked this report in that it gave some clear estimates of the return. I think maybe at times the quality and safety might be not top of mind, and that's uncomfortable to say, but I think that's the reality. And so it's I think it's helpful to have reports like this that put a number to it and hopefully raise some attention. Some of that maybe I'm too optimistic at times, but I think some of the not in the top of mind might be a bit of success that we've made and progress we've made in patient safety, in that a hospital health system leader might be, okay, we have an established program, it's doing things, it's doing um, good work, and we're doing a decent job. So I think some of this gets back on the quality leader to use a report like this to um, be willing to rethink things, look at new methods, and advocate for it. And then to your point, Haley, of interacting with other leaders, I think a kind of fundamentally a chief financial officer and chief quality officer kind of see different things, use different vocabulary, sort of see the world pretty differently. And the CFOs may not be, the CQO may not be like the naturally working together. So I think it's a little bit on the chief quality officer to take a report like this, to build the relationship, have the conversation, learn the vocabulary, and sort of build the connection.
Yeah, I appreciate that. I know when I hear my system leaders speaking, there are certain words that they do use, and I like to use their words back to them, especially when I'm asking for money to grow a program or to add to the staff for the things that I need. That's a really great point. So, using this really rich, important report and then combining that with what's important to the executive team and what their words are, how they express themselves, and the desires and the alignment of their goals is really powerful. And so, Chris, based on the references to technology in this report, what is your advice to organizations that are evaluating these types of tools?
Yeah, so I mean, I think it's a lot about framing the conversation with the people who make the decisions about maybe spending the money to invest in solutions like this. And there's so many powerful insights about the limitations of manual event reporting and the role of trigger tools and AI and the real critical importance of aligning safety culture with that real-time surveillance aspect. And I think, this data, it's very clear, right? Organizations that are investing in a modern safety infrastructure are really seeing not only safer care, but really measurable financial returns. And the report really highlights that. And reducing preventable harm it's no longer a clinical imperative. It's really becomes a strategic advantage when you're able to not only improve care, but also financially have a great return on your investment. Like, it's kind of a no-brainer. So really framing that conversation and getting those people who make those decisions to understand the value of these solutions and what they can bring to your organization to improve safety is how I would kind of approach that.
Yeah, a strategic advantage. I like that, Chris. Really terrific terminology. All right, so we have some time. So we're going to take a couple questions from our audience, and I'll tee these up and work through these with the team. So we'll take a couple of them, and then we'll have some final words for everyone. So here's a really great question, Chris. I'll target this one at you, and then to you, James. But the question is, what are some examples of types of events that will have rules to detect them? So in a practical way, if we're talking about electronic triggers, what are some of the specific types of rules or alerts that can be created to identify events?
Yeah, so I'll give some of the examples that we've implemented on behalf of some of our users. One would be HAIs. So when a patient has a healthcare acquired infection, we can trigger a safety event to be created in the safety application and pull over the pertinent information from the patient's chart to help aid in that investigative process. So that's one example. In the medication safety space, we've done a number of rules around hypoglycemia related to insulin administrations, drug levels being out of range after receiving certain types of medications, reversal agents being required to be given after opioids or after benzodiazepines, and things like that. So those are some of the rules that we're currently running today. And organizations that send us more information and documentation is really where we want to go next. And how can we use NLP to detect when an adverse drug event is documented in text, right? Or when a fall is documented in text. So that's really what our data science team is working on now. They're actually working on several models related to those specific topics that we hope to be able to pull in to the workflow here very soon.
Yeah. And James, what do you think would be some of the really important events you would want an electronic trigger to bubble up for you and your teams?
I mean, I think my answer is that there's tons of evidence here, and I think it's a little, and in like I know pediatrics best. I think there's tons of great papers that show the value of this approach and can see all the triggers and rules they used. I think the there's an adaptation process that needs to happen to pick the ones that matter for the problems, risks you see in your organization. And with my hospital being quite specialized, we've had some iteration and challenges that, all right, what does a naloxone trigger mean in our context, for example? So, like, it's hard for me to pick. I think it's something that each organization has to decide and adapt and see what works for them, and then follow through to use the data over time and use it to improve.
Right. Here's another question. This one is just simply, what's the name of the safety event reporting systems that use AI technology? And so the one that we're speaking to today is the Inovalon, the Vigilant Safety Management platform in particular. I'm sure there are others out there that are doing similar things or, are moving in that direction, but I'm actually not aware of any that are using the rules-based AI to create the electronic triggers in the background currently. And Chris, here's a good question around interfacing. Do these types of tools interface with current EHRs?
Yeah, absolutely. So in order for us to run the auto detection rules, we would need to get data from the electronic health record, and there's various different methodologies out there for us to be able to get that information and run our rules-based AI against that data. But certainly an interface, an HL7 interface, or some sort of a API or emissary call is another way that we can obtain that information. And then some of our customers also are able to launch the safety event reporting application directly from their EHR and preserve patient context as they come into our application as well. So there's several different ways that we integrate with electronic health records, all of the major ones, and even some maybe you've never heard of. So we're very in tune with integrating with many different electronic health records and can handle many different types of data.
Thanks, Chris. And so, James, I have a question for you. With bias and equity involved, how can we try to streamline and start with AI implementation in organizations?
Yeah, it's the maybe simple, non-nuanced answer goes back a little bit to governance and making sure that the equity and bias is one of the risks that the governance team would would be watching for as different things get implemented in predictive analytics AI. I guess I would maybe also turn that on its head a little bit in that if you don't have a more sophisticated approach to event detection, I'd argue you don't really know all of the equity issues that you may have. So a deeper, more systematic understanding of the risks and the harm that are happening, that then you can interrogate based on race, ethnicity, whatever demographics, actually will give you a better understanding of the equity problem. So I would there's a scary world of LLMs and bias, but that is real, and equity concerns. But then there is, I think, a more simple way forward, and that will actually give you more information on the risks, including based equity risks or differences.
Yeah. Thank you for that. And thank you for all the terrific questions from our audience. We'll be able to follow up with you, I believe, after the call, but we're almost at time. And I wanted to give the panelists an opportunity as we look ahead. What is one bold step that you would encourage organizations to take in the next 90 days to move from reactive to proactive, data-driven approach for safety? James, start with you.
I think maybe it's the internal work of the quality and safety leader of, are you comfortable with the same thing, or, that you've been doing, or are you open to having a deeper view of event detection, having other methods for gathering information on how work is actually performed, or other proactive risk assessments. So I would put it back, kind of speak peer to peer and say, look to yourself first, and what do you need to know to lead differently and rethink things.
Yeah, challenging ourselves first. I like that, James. Chris, how about you? Final words.
Yeah, so I totally agree with James. And I mean, obviously, the shift to utilizing these types of technologies to augment your voluntary reporting is going to undoubtedly increase the amount of events that are being identified and uncover all kinds of new areas of risk you may not even be aware of. And you really need to be able to build that foundation of continuous learning and improvement if you want a program like this to be successful. I participated in another panel recently, and one of the participants said, if you want to have a strong culture of safety, you first need to have a culture of learning. And I think that really resonated with me. And so I guess that's a very long-winded answer to say my suggestion would be to start really building that framework and getting buy-in from all levels of your organization to explain what's going to happen. We're going to have more events being reported, and this is good because we can do this with that information to really foster that culture of learning. Some leaders don't really think that having more events reported is a good thing. They see it as a bad thing, right? So how can we get the buy-in, as James said, and really looking internally at yourself to say, am I ready to embrace this technology? And because it has to be an organizational wide thing.
I like that, a culture of learning amongst yourselves and then using that information to be practical. How do we address this? How do we carry it forward and close the loop? So, friends, we are out of time today, and it has been a wonderful panel. And I'm so appreciative of James and Chris and the Leapfrog group for having us. It was a terrific time. I hope that you learned some really important foundational pieces around culture of safety. We hope that we have expanded your knowledge in the way of how AI can be used in the patient safety and safety space, as well as electronic triggers. We look forward to catching up with you at any time. You can see the contact information here, and I hope you all have a great rest of the day. And at this time, we'll end the webinar. Thank you for joining us.